So as Dr. Steph said, I'll be talking today about an option of a stem cell transplant called haplo-identical stem cell transplant. And we'll go over some basics first to introduce you what we mean exactly by haplo-identical and how the process goes. So I will be talking initially about introduction, then I'll talk about the type of antigens that we look at matching when we pick a donor for bone marrow transplant. I'll talk about the donor options and the eligibility criteria. I'll tell you how haplo-identical transplant works. Then we'll discuss the advantages of this approach, the outcomes of that, and who should consider the haplo transplant. And then I'll give you a quick summary. So allogeneic stem cell transplant is a transplant from someone else. And it is important to talk about because it's a potentially curative therapy for a lot of blood cancers and some non-hematological conditions as well. Stem cells, bone marrow, we use the terms alternatively, either stem cell transplant or bone marrow transplant. They essentially mean the same. Stem cells are the mother cells of all types of blood cells. They divide and differentiate in our bone marrow to give rise to all types of the blood cells. And we obtain them for transplant either from going into the bone marrow directly or from the peripheral blood from either a related or an unrelated donor. This cartoon is basically represent our cells, and our cells, they have surface markers or proteins that are here spiking out of the surface. HLA antigens, they stand for human leukocyte antigens, and they are type of proteins that are present on almost all types of cells in our body. And the immune system uses these markers to recognize cells that belong to the body. This way, the immune system will keep them alive and differentiate between cells that come from outside the body. So if the immune system recognizes something as foreign, it typically attacks that and destroys it. And this is the importance of the HLA antigen, and they play an important role in transplant process. We inherit our HLA antigens from the mother and the father. We get half of our antigens from the mother and half of them from the father. And if you follow this diagram, if we think that this is our patient here in the square, he got half of his antigens from the mother and half of them from the father. So when we try to pick a donor for him, we try to match the patient at both sides. And that would be a full match if we can't match both sets. If we cannot, then we try for half match only, which is the haplo transplant I'm talking about, and we call it a half match. So this patient, if we look at his siblings, by common laws of inheritance, he has only 25. With each sibling, there's a 25% chance that the sibling will be a full match, and there's a 50% chance that the sibling will be a full match. So when we consider that option, we have more donors to consider. So the role of HLA matching is to increase the likelihood of a successful transplant. It improves engraftment, which is when the donated cells start to grow and make new blood cells in the patient. And it reduces the risk of a significant complication of a transplant called graft versus host disease. This can range from a mild rash to potentially serious complications, and it occurs when the new immune system of the donated bone marrow starts attacking the patient body. And this is one of the things that we always try to prevent when we do allotransplant. So with that, the donor options are either a matched sibling donor, and as I said, with each sibling, there's only 25% chance of being a match. If we cannot find a matched sibling donor, we go to a matched unrelated donor in the donor registry. These are volunteers from around the world that signed up to donate cells for people who need. And if that's unavailable or not an option for any reason, then we go to alternative options, either the half-match transplant or a cord blood transplant. Normally, we look to match the donor with the patient's HLA antigens at all sites. The closer the match, the better the outcomes. But as we said, with the smaller family sizes, only 30% of patients can find a matched sibling donor. So we always go, the second step is to go to alternative options, and with that, we now say that nearly all patients should have a donor to undergo the process that they need to be cured from their cancer. The donor eligibility, we look at different things, including the donor health, the degree of HLA mismatch, the age, the relationship to patient, the gender, and the blood type. Now, the haplotransplant requires only a half set of antigens that are matching the patient antigens. So that increases the potential, the number of potential donors to include the biological parents, the biological children, the full siblings, and the half siblings. And with these options, all patients will have a donor. This diagram talks about the allotransplant process in general. We start with the donor. We collect their cells either directly from the bone marrow or from the peripheral blood. We process the cell and cryopreserve them if there's a delay between the time of donation and giving them to patients. If they are done in the same day, especially when we're dealing with sibling donors, then we don't need to do this step. We give the patient chemotherapy, meanwhile, while we are doing this process to prepare their body to receive the new cells. And then we infuse them to the patient just as we infuse blood transfusions, red cells and platelets. The haplotransplant has some modifications of this process. The initial process that I just talked about is the same, but 3 days after a transplant in the haplo setting, we give the patient a high dose of a chemotherapy called cyclophosphamide. The reason of this step is to reboot the immune system. This cyclophosphamide chemotherapy, it spares the donor's stem cells and allows them to establish the new blood cells and the new immune system that we need. But at the same time, it retains the budding immune system, retrains the new immune system to see the patient's body as a friend and prevent the patient from rejecting the transplanted bone marrow. The advantages of this approach is the near universal availability of highly motivated donor. We're talking here about family members who really love their patients and they want to help them quickly get over their cancer. The demographic data shows that on average, each patient has about 3 potential donors when we consider haplotransplant, compared to the lower numbers when we were talking only about matched siblings. It is rapidly available because these are family members that are highly motivated to donate. And it has the ability to collect adequate doses of stem cells compared to cord blood, which always limits us with the number of cells that we can get. The other advantage is the availability of the donor for repeated donations, and this becomes important if we need to treat relapse or we need to give a stem cell boost to help the hematological or the immune system of the patient. And potentially, it can lower the chances of disease relapse because we know with higher level of mismatch between the donor and the recipient, the immune system reacts more strongly against the cancer cell, and it can, in some cases, lower the chances of relapse, which is something we call graft versus a tumor effect. Outcomes. So outcomes vary a little bit between the different studies. I found this study really nice. It is a study that compared actually cord blood to haplotransplant. So I picked the graphs that talks about haplotransplant. In this one, it shows that the 6-month survival is about 85%. And we know that when talking about allotransplant, the initial period is the most critical period when we talk about survival. So 85% is a very good outcome. 1-year cancer-free survival is about 50%, and 1-year overall survival is in the range of 60%. The rate of severe acute graft versus host disease in the first 3 months after a transplant is about 30%. And that's with the use of post-transplant cyclophosphamide. And the rate of a chronic graft versus host disease at 1 year is about 13%. The risk of death at 1 year because of causes other than disease relapse is in the range of 7 to 10% here. 1 year risk of relapse, this is the primary disease or the primary cancer coming back, is about 45%. And the most frequent cause of death in these patients is relapse. So as I said, with haplotransplant, the advantage of having the donor available for repeated donation of stem cells is really important to treat this group of patients who relapse after a transplant. Who should consider haplotransplant? Well, first, it has to be done for a patient who has a type of blood cancer that needs an allogeneic stem cell transplant, and he has no available matched sibling donor to donate. And a suitably matched unrelated donor cannot be found in the registry, or if we need to move very quickly with the transplant process because of risk of disease relapse. You know, when we look at donors in the registry, there is some delay in finding a donor and, you know, working around their schedule to have them evaluated for donation, collect their cells, and then coordinate the whole process to treat the patient. So with that, we can avoid some downtime when we go with the haplotransplant and use a family member. So to summarize, haplo-identical bone marrow transplant is a half-matched transplant from a donor, typically from the family. Potential donors are biological parents, biological children, full siblings, and half-siblings. And most patients have more than one first-degree relative willing and able to donate. The advantages are the rapid and the universal availability of donors. Adequate doses of stem cells can be harvested, and the availability of donor for repeated donations. The major challenge is the graft versus host disease, but the outcomes are very encouraging with the use of post-transplant cyclophosphamide as part of the immune suppression regimen when we use this approach.